Okay, good afternoon, everyone, and thank you very much for being there. Each one of you is highly appreciated because I think you have made special effort to be in this hall. Otherwise, post-lunch session halls are usually vacant, and also this happens to be the last session of the day. We will be talking about avoiding and recovering from BLEF failures in trabeculectomy. So trabeculectomy, we know, is the commonest procedures that we do, and this is still kind of the mainstay of glaucoma therapy. But unfortunately, there's a significant failure rate with this procedure also, and very often we get into trouble. So idea of this instruction course is how we can avoid, how we can make our results better, and also if something is not right, how we can kind of rescue from that position. So we have with me, I have faculty, very well-known faculty, Dr. Sushmita Kaushik. She is professor of ophthalmology at PGI Chandigarh. I am Dr. Pandav. I am also from the same place. Dr. Parul Pujani is with us. She is professor of ophthalmology at Government Medical College, Chandigarh. And we have Dr. Faisal with us. He is, again, a lot of glaucoma experience. He is associate professor with us at PGI Chandigarh. So what we want to basically, the course layout is that I'll be speaking about glaucoma surgery, why it fails. I think very important to understand the basic mechanisms, so we'll touch upon them briefly, and what kind of our hypothesis is about the surgical failures, and how we can do trabeculectomy, so that it succeeds and it doesn't fail. So what are the steps that we need to take? Then what are the risks for surgical failure, and when would you and how do you take care of them? And then we also have to take care of identifying failing BLEBs. And then finally, I will talk about the how to rescue if the BLEB has already failed. So Dr. Faisal has to go, so you want to take your after my talk? Yeah, okay. So there's going to be a little bit change in the schedule, but he has a presentation in the other hall as well. So why glaucoma surgery fails and what is the current understanding? So this surgery was done, this is second post-operative day, and there are two different eyes done by the same procedure, same surgeon, and identical procedure basically. And I'll ask you which surgery you think, they look very similar to, but what is your guess at this point of time? Can you say the BLEB A and BLEB B, which one you think is going to do better? Is there any clue, or can you predict? Who says A is better? Raise your hands, please. No, anyone for the B? B is going to be better? Okay, so I see more hands in favor of B. Maybe some clue there. To me, they actually look identical. So let's fast forward to day 7. And this is how the BLEB looks at day 7. Now you can see in the in the BLEB A day 7, you can see some vascularization is happening. B has not shown much activity in that area. So what is your take now? How many of you think the BLEB A is better or do better? 1. And how many of you think BLEB B is better? Again, more number of hands for the BLEB B. So this is what happens 8 weeks down the line. So look at the BLEB A and look at the BLEB B. So they actually started very identically. Everything is identical. Post-operative care is identical, but something goes wrong in one BLEB than the other. And it's very hard to predict. So BLEB A was actually an excellent BLEB. This is the kind of ideal BLEB we want: diffuse, low-lying, normal vascularity and good IOP control, and B has become a tenon cyst. So, but if you look these BLEBs carefully, you would find that there are clues in that, which could perhaps predict, which BLEB is going to do better. So if you look at normal wound healing, so that actually brings us to why the BLEBs fail. So in the normal wound healing, we have a coagulative phase, we have inflammatory phase, scar formation and then the wound remodulation. And if you can see from the graph, most of the fibrosis actually goes up steeply around day 7. And after that, day 14, there's not much of a change. After that, actually is a modulation, but this is a normal wound. And in trabeculectomy, this path is not followed. And this is quite more complicated because in trabeculectomy, what we have tissue trauma, we have foreign body, and we have aqueous flow. So if there's only tissue trauma and foreign body, the wound actually heals very quickly, but it's the aqueous which creates problems. So we try to understand what happens in the aqueous, what that aqueous do, and we replicated a rat eye model for glaucoma surgery. And what we found that the pro-inflammatory cytokines like TGF-beta, they are actually consistently and markedly elevated and for a very long time. So in mouse eye, it took almost 7 days for them to come down, but equivalent to the human eye would be perhaps 7 to 10 weeks. So that means the wound healing is not actually stabilizing in human after glaucoma surgery for at least 2 to 3 months. And this is the anti-inflammatory panel. That means the cytokines which are good, which will help your heal, have a lesser scar. So they are actually reduced, their expression is reduced, and their expression is delayed, by almost 1 week, 1 to 2 weeks sometime in rat eyes, and in our human eyes probably the similar time. So what we understand is the presence of aqueous increases expression of these pro-inflammatory cytokines like TGF-beta, and it inhibits or delays the expression of anti-inflammatory cytokines. So that's what kind of complicates the wound healing. So again, the problem, then we try to understand what does aqueous actually do. So we set up another experiment. Here we looked at the role of the aqueous in how it is influencing our wound healing. And if you look at that first bar, that's kind of an experimental bleb where no fluid is flowing through it. It's just a bleb created by a device. And you can see the bleb is actually quite porous. The aqueous flows through, when we test it, is very porous. But if you let the aqueous flow through the implant or the bleb, it reduces within 4 weeks. Actually, the porosity goes down 80%. And these blebs, they have a very thick wall, the blebs which are exposed to aqueous, and the blebs which are not exposed to aqueous have very thin and porous wall. So that means the aqueous is actually doing something there. And we know that there are cytokines in the aqueous like TGF-beta which would complicate. But however, if we remove the aqueous and we just use BSS instead of aqueous, similar things happen again. So that means aqueous is there, but there is other things as well. So what this means is that aqueous cytokines may be responsible for blood failure, but the balanced salt solution has similar effect. And so that probably there is a kind of a fluid stress is happening in the blebs, which is contributing towards capsular thickening and failure. And what we believe that capsular thickening might be actually a secondary phenomenon. Blood actually starts failing much before that. So this is our model of pathophysiology of blood failure. So normally, after surgery, the blood should heal within, and the capsule should stabilize within 4 to 6 weeks. But what happens when you switch on the tap and the fluid start flowing through it, those cytokines are reactivated, or they kind of the healing process is interrupted and it gets very prolonged. And then there you have a proliferation of the fibroblast. They get converted into the myofibroblasts, and subsequently they contract, the bleb becomes small and thick-walled, and IOP goes up. And when the IOP goes up, the fluid stress increases again. So this is a vicious cycle which kind of ends with the bleb failure, so unless you interrupt it some way. So how we can interrupt this vicious cycle, that's important. So number one, you can restrict fluid into the bleb. So that means immediately after surgery, it's better to have a tight closure in the first few days at least. Still some wound healing has happened, and too much of flow is not really required. We use anti-inflammatory that we all know to cut down on the inflammation. We use anti-fibrosis, mitomycin C. However, we do not know what is the exact timing should be for the mitomycin C. We are using on table, which to my mind is too early, but we don't know what is the best time to use mitomycin C. We have tried anti-VEGF. There are some studies where anti-VEGF has been used in glaucoma surgery with good results, so there's a role for that perhaps. and also the keep IOP low. And there's now evidence, at least in from our implant experience, that if you keep the IOP low in the early postoperative period, they do better in the long run, and that probably would be true for the trabeculectomy as well.